Hi, well, welcome everybody. Thanks so much for joining us today. Welcome to this BNSSG Training Hub webinar all about endometriosis. So my name's Dr. Sam Morgan. I'm a Women's Health Fellow with the Training Hub, and I'm really pleased to be joined by Harriet today, who's also a GP, works in Yate and also a menopause specialist. Harriet's going to be picking up your questions from the chat and can kind of clarify anything that's unclear. So please do feel free to post regularly in the chat if you'd like a bit more detail on something or if something wasn't clear enough. Roger's here from the Training Hub, so if you've got any technical issues, please reach out to him in the chat during the webinar. And the session's being recorded. You'll be emailed a copy of the slides as well as a resource sheet later on, and there'll be a feedback form sent out as well. Please do fill this out. It's really, really useful in terms of the planning of future events. So in terms of what we're going to look at today, I'm going to try and keep it really relevant. Think about what we can do in primary care to both diagnose and support people with endometriosis today. I want to start by acknowledging that although I'll be referring to women today, not all women were assigned female at birth, and some trans men and non-binary people can also experience endometriosis. So we chose endometriosis because it's a hot topic, it's really common, and it's easy to miss. But there are recognised treatment pathways, and we're going to signpost you to the guidelines, to lots of really useful resources, and try and keep it really practical and relevant. And with that in mind, I'm going to start by just talking through two cases to begin with. And we'll come back to these again at the end of the presentation to see if what we've looked at today might help us with these cases if they were to present again in the future. So the first case, a 37-year-old woman who has had painful periods since they started when she was 12. She started on the pill as a young teenager, but even with the pill, still would often miss school and then later miss work due to the trouble from her periods. She'd often feel nauseous, would sometimes feel faint, and twice had been to A&E because of the pain. She was a frequent attender, somebody that we saw a lot of in primary care. And her symptoms really ramped up when she stopped her pill to try to conceive. The pain became much more severe, and it was at that point she was referred to gynae and diagnosed with extensive endometriosis at laparoscopy. Interestingly, her scan had been completely normal.
Got it.
Yeah, got 10 minutes.
And then the second case is of a lady who was diagnosed at the age of 48. She had a really long history of bowel symptoms and had repeated lower GI investigations over a 10-year period that were all normal. She resigned from her job as a lawyer due to the impact of her symptoms on work and was presumed to have IBS and prescribed antidepressants. She developed, though, a significant nausea, was really struggling to eat and lost a lot of weight and presented with a perforated bowel, secondary to obstruction, and was found to have extensive endometriosis at surgery that required a resection, hysterectomy, and she ended up needing to be on ITU. So quite an extreme presentation. Interestingly, again, in retrospect, she does have a history of infertility, although hadn't had painful periods or pelvic pain. Her symptoms were very much lower gastro symptoms. So it's really tricky, isn't it, to diagnose? There's so many different presentations, and that's something we're going to really spend some time looking at today. But let's start with the basics. So what is endometriosis? Well, it's a chronic inflammatory disease defined by the growth of endometrium-like tissue outside of the uterus. It's hormone mediated, it's associated with menstruation, and these deposits of tissue are mostly in the pelvis, so on the ovaries, in the pouch of Douglas, But we can get extra pelvic deposits in up to 10% of people, such as in the bowel, even in the pleural cavity. And each month, essentially, these deposits are reacting in the same way as endometrial cells, and this can cause significant pain in these different areas. And there are 3 types of endometriosis in terms of a kind of classification. Ovarian, where we get those cysts, the endometriomas or chocolate cysts as they're known. And then there's the really deep kind of infiltrating endometriosis, where you can get nodules of tissue quite deep below the peritoneum. And also superficial or peritoneal endometriosis, where the deposits are more on the surface of the peritoneal lining. And these types, you can get a variety of them. They're not mutually exclusive. And this image I've taken from the differential diagnosis list from the clinical knowledge summary. And I think this summarises, if there's one slide that summarises the difficulties, the challenges for us in terms of diagnosing endometriosis, this is it. Because the differential is huge. From constipation through interstitial cystitis, from adenomyosis, PID, ovarian cancer, musculoskeletal pain, it's really, really wide-reaching. And this can make it, really quite challenging. There's lots of different things that can present in similar ways. In terms of what causes endometriosis, we still don't know. It's not been, unfortunately, very well researched. The actual mechanisms are unclear. There are lots and lots of theories, but no definitive answers as yet. But we do know there are a number of risk factors, and there does seem to be a genetic predisposition. So that can be something that's useful for us to ask about potentially when we're seeing patients. So if a first-degree relative has endometriosis, there's a 7 to 10-fold increased risk of developing it themselves. So really quite significant. So these risk factors potentially are helpful to think about if you're seeing somebody with a presentation where it could be. There seems to be an association with autoimmune disease. This isn't really clear as to, again, the mechanism. We know that it's a sort of chicken and egg situation. There's a correlation between the two things, but it's unclear in terms of the relationship as to which way round. And as we've said, it's really, really common. So 10% of women being affected between puberty and menopause, although of course the impact can be longer than that too. So that's over 1.5 million in the UK. And this quote is from Candice Mackenzie from a group called the Endo Warriors. And she says, if you know 10 women, then you should know endometriosis. So as common as asthma, something that we should be thinking about really, really regularly. Again, tricky, not everybody will have symptoms. We know sometimes diagnosis can be an incidental finding at a laparoscopy, perhaps it's being done for another reason, but the majority will. So Harriet, any questions so far in the chat before we delve a bit deeper? Oh, you're on mute, Harriet, sorry.
There are no questions in the chat at the moment. Please do put things in as we go along, everyone, and we can try and answer them through. We'll have various points through like this where we can try and answer people's questions. I just noticed that chronic pelvic pain wasn't on the differential diagnosis list that you put up there, Sam.
Probably one of the most common sort of presentations, isn't it? Yeah.
So yeah, just a thought, comment.
Yeah, thank you. So When the Women's Health Strategy was brought forward, there was a call for evidence from the public. And one of the most common areas that the public wanted more information about was menstrual health. Nearly 50% of respondents selected that as being something they just didn't feel they knew enough about. And of course, one person's experience of menstruation is their only experience. They don't know what somebody else's normal is. They don't know if they themselves are having a normal experience. So for me, this is where we need to start thinking around what is a normal period? Should we expect cramps? Should we expect pain? When does that become something to worry about, a symptom of a disease potentially? And Endometriosis UK did some research showing that 54% of people didn't know what endometriosis was, and this increased to 62% in women between the ages of 16 to 24. So if there isn't that same sort of awareness in terms of symptoms, again, it's hard for people to join the dots and kind of make those connections. So in England now, menstrual well-being is on the curriculum in school. It's not as yet in Scotland and Wales. But we know there are still taboos, particularly in some cultures, around talking about periods, talking about what's normal, talking about pain, on what can be experienced and what maybe we wouldn't expect to be experiencing. These two resources, 28-ish days later and Period Power, are non-medical resources, but both potentially quite useful at helping people understand the menstrual cycle, understand what is normal in terms of menstrual health. And I'm just going to try and, throughout the presentation, get us to think about what the impact can be. These quotes are all taken from Endometriosis UK from people who have a lived experience of endometriosis. So in my teenage years, I always had quite heavy periods, but was told not to think anything of it, and that painful periods are normal, including by my friends and family. In my early 20s, I started taking the pill to help with irregular bleeding. One evening, I was taken to A&E with abdominal pain. I had investigations for appendicitis, UTI, kidney infection, and countless internal investigations. After numerous appointments and visits, I was referred for laparoscopy and was diagnosed with endometriosis. And this image is from the Women's Health Strategy, and it identifies different areas for us to focus on in terms of women's health and the sort of population health in the UK. And why do we need a women's health strategy? Some may say, well, we've still got quite a gender health gap. We know in the UK, women on average live longer than men, but they spend a significantly greater proportion of their lives in ill health. And there hasn't been much of a focus on menstrual health, menopause, endometriosis, many of these different presentations. And women have been underrepresented in research, in clinical trials. So we haven't known as much about conditions that only affect women, and also about conditions that can affect men and women in different ways, and the impact of hormones on many different presentations. These books both give quite interesting insights, and I think in healthcare we've often thought about the default body as being the male body, and the default experience of illness is the male experience of illness. So when we're taught by perhaps a colorectal surgeon about bowel symptoms, we'll learn all about the bowel, but we won't think, well, how may these bowel symptoms be different for women? How may hormones be affecting these bowel symptoms? Could there be a link actually, and this could be different for this woman's experience? So for me, this is quite an important part for us to think about again when we're thinking about recognizing endometriosis, is just thinking differently when we're seeing women with bowel symptoms, with urinary symptoms, and remembering just to kind of think hormones and think about whether there's a link through to the menstrual cycle. So another example here in terms of the impact and the kind of worries around not being diagnosed. When I first went to the doctor, I was tested for a lot of different STIs. Sex was painful. I was experiencing a lot of pain in my pelvis, and my periods were painful and difficult to manage. The STI test came back negative, but they were sure this is what it was. I was sent on my way with some antibiotics and left explaining to my partner that I'd been tested for STIs, but with no answers as to what this pain could be. I was left feeling confused, upset, and embarrassed. A week later, following a lot of pain, I was rushed to hospital with suspected appendicitis. This was ruled out. I was yet again left with no answers. Years later, I was diagnosed with endometriosis after my friend mentioned the word to me. I looked at the symptoms, found the Endometriosis UK website, and it was like a light bulb moment. I underwent laparoscopy and was diagnosed with endometriosis. And it's so tricky, isn't it? Because of course, with pelvic pain, there are lots again of differentials for us to think about. We of course need to think about PID. We don't want to leave that to go untreated. We need to think broadly. And for us in primary care, we're seeing people often at the beginning of their story. And it's much easier in retrospect when we look back at these different presentations. But a really common theme from speaking to people with a diagnosis that unfortunately is often made quite late with endometriosis is this uncertainty, this confusion, this feeling around not being seen, not being heard, not being understood in terms of what was happening. So the impact, as we've seen already, can be quite significant. And it's not just physical, it can also be in terms of mental health and also in terms of life with relationships and impact on work. There's some slides coming up from a report by the APPG, the All-Party Parliamentary Group on Endometriosis. They asked 10,000 people about the impact of their symptoms on their ability to lead their life in the way they wanted to. And the figures are quite astonishing. So of those 10,000, 95% were experiencing pelvic pain, 93% fatigue, 85% heavy menstrual bleeding, 73% had had a difficulty conceiving. And overall, 95% said that their endometriosis had had a negative impact on their well-being. So in terms of physical health, pain is often one of the most significant symptoms. This can be secondary to adhesions. Fertility can be impacted even with quite mild disease. You can get bowel symptoms. We can see a lot of fatigue. And there's an almost twofold increase in the risk of ovarian cancer. In terms of the impact on emotional health, on mental health, again, it's really significant, with many people saying that it's really affecting their ability to live their lives in the way that they want to, and often quite strong themes around isolation and really wanting more psychological support alongside their diagnosis. And work too, there's a significant impact on people's work lives and on their schooling. So in this same report, 42% said they often or very often had time off school because of symptoms, and 38% were concerned about losing their job, 35% having a reduced income due to their condition. It's thought that endometriosis costs the UK economy £8.2 billion a year in treatment, loss of work, and associated healthcare costs. So another pause for questions, just to see if there's anything you want to look at, and then we're going to come on to really looking at presentations and diagnosis and management.
Thanks, Sam. Yeah, just really powerful numbers there, isn't it? Just how much of an impact it can have on people's quality of life and work and schooling. Kevin's asked a good question or raised an issue. He said that you mentioned endometriosis is inflammatory in nature, and in that context, does it cause any raised inflammatory markers that can be helpful, like CRP? He gave some context in that I think he's had a case of sort of a long-standing lower abdominal pain, and investigations, including CT and ultrasound scan, were unremarkable, and the only blood result was a raised CRP of the only abnormality on bloods was a raised CRP of 88. I don't think you could put down a raised CRP just down to endometriosis. I think if it was being caused by endometriosis, it would be causing significant problems like your case of perforation or other significant sort of inflammatory responses elsewhere. Just as it is in itself, I don't think it would cause raised CRP. Is that your?
Yeah, I'd agree, Harriet. Yeah, I certainly wouldn't expect it to cause anything near that level of CRP. No. It's that sort of low-grade chronic inflammation rather than an acute inflammation. So yes, I'd be thinking about something else going on too.
Yeah, definitely looking for something else, exactly.
Super, thank you. Well, let's start then by having a real look at some of the common presentations. Let's kind of think about how we can try and recognise this. So pain, as we've said, is one of the key symptoms. So pelvic pain, often worse with the periods, painful periods. They can be really very painful. That pain can radiate to the back, to the legs. Painful bowel movements. So again, often worse with the period. So often that cyclical nature. There might be nausea, constipation, or diarrhea with the period. Of course, that can be very common for everybody without endometriosis too, to potentially have some diarrhea with the period. Painful urination, again, often particularly with the period. Painful sex during or after. And often it's that sort of deep pain rather than more superficial pain. Heavy menstrual bleeding is really common too, and infertility. And as the site of the endometriosis can vary person to person, that the sort of range and severity of symptoms can vary too. And for some, the symptoms can be quite mild. As we said, you do get incidental diagnoses. For others, the symptoms are really, really significant. So the pain is often cyclical, typically will start a couple of days before or during the period. There'll often be associated symptoms like fatigue and potentially anxiety and low mood as well. Depending on the location of the endometriosis, where those cells are, they will bleed. Some women will get things like nosebleeds cyclically. So sometimes the symptoms can seem quite out of kilter with what we might expect in terms of that classical kind of pelvic pain type of picture. And this next slide is from the NICE guideline. It was updated just last month. And this helps us to think around the diagnosis as to what we should be looking at. And we know at the moment, the average time to diagnosis is 8 to 10 years. I think that part mainly reflects the difficulty in recognition, obviously the need for things like laparoscopy too. We haven't got simple, easy tests that we can do to say yes or no. But again, as we've said, these people are well known to us. Prior to receiving a diagnosis, 58% of people have seen their GP more than 10 times about those symptoms. 21% have been to the hospital 10 times or more with these symptoms, and more than half have been to A&E. So these symptoms are causing a lot of difficulty for people on a long-term basis. The APPG have targeted the government to try to reduce the time to diagnosis to less than 4 years. And the NICE guideline summarises these areas that we've looked at already as being the main symptoms to be thinking about. They encourage us to consider things like pain diaries, symptom diaries. These haven't been shown to lead to an earlier diagnosis in studies, but they can be really useful for women to be able to show the impact, what their symptoms are, and particularly that kind of cyclical nature. And I'll share some resources later on for links around things like symptom diaries. As we said, family history, I think that's quite an easy one for us to think about. And remembering that 7 to 10-fold increase with a first-degree relative, potentially quite a key factor to ask about in the history. And then thinking about the impact of those symptoms on somebody's life. Again, we're good at that biopsychosocial model, thinking around what these symptoms mean to somebody in terms of their day-to-day life. This slide is from the RCGP guideline. They have this quite useful NUB summary, new and useful bits. It's essentially very similar, encourages us to think about pain, asking about periods, asking about urinary symptoms, fertility, reminds us that a normal examination doesn't rule it out, a normal scan doesn't either. And of course, we may still need to do these examinations and different tests because we don't know this is definitively endometriosis. We need to think about our broad range of differentials. And again, just thinking around having quite a low threshold to refer, we'll come on to looking at the referral guidelines later, if people are having quite a big impact from these symptoms. In terms of tests, again, this is from the updated NICE guideline. It recommends offering a transvaginal scan even when the examination's normal, but also acknowledges that even if the scan then is normal, it doesn't rule it out. And I think, again, this is important for us to remember. Often we might see somebody and do that initial workup and refer them for a scan. And then perhaps if somebody goes onto their app and sees scan normal, no action, they may not then come back to us. So for us to be thinking around that proactive follow-up, bringing people back, even if their investigations are normal, because a normal test doesn't rule it out. So it's important we do it, but it doesn't rule it out. This is the summary from the RCGP guideline. Again, it's very similar. It's quite consistent with the NICE guideline too. So encouraging us to think about our scan, thinking about investigations for our other differentials too, depending on the presentation. Not thinking about requesting CA125 and MRI in primary care. So very similar kind of guidelines for us. Interestingly, again, the APPG asked people what would have improved their experience of getting a diagnosis. And most of the themes that people raised were things like being taken seriously, being listened to, and being referred a little bit earlier. Gynae referral rates and wait times have been in the news again over the last couple of weeks. So it's really difficult, isn't it, with the system as is at the moment. Even when we do refer, people are still going to be waiting a year or two very often from that stage too. And then in terms of specialist investigations, again, this is from the NICE guideline. So obviously this isn't our remit, but just to share with you so that I think it's important that we're able to talk with people about what to expect when they do go to see gynae. So MRI is sometimes used, but laparoscopy is still seen as being the gold standard in terms of visualizing and seeing that endometriotic tissue. So it could be a diagnostic laparoscopy. It could be that treatment is planned at the same time. So again, the guideline helps us in terms of understanding what then is going to be offered in terms of diagnosis. So any more questions coming in before we start to look at management?
Yep, some good ones. One comment was along the same lines as the raised CRP. Somebody has noticed that a patient of theirs has had not very raised, but slightly raised platelets for very many years, and was wondering whether that could be the cause of caused by endometriosis. And I think if other causes, which in this case have been excluded, and it's severe endometriosis, I've done a quick literature search as we've been talking. It can be severe peritoneal deposits or endometriosis can cause a borderline sort of a raised platelet. So I think if they're stable and a bit high, then you could put that down to that. There were a couple of other questions. One was, what signs may you see on the cervix which would indicate endometriosis during examination? So, I mean, on bimanual, you can sometimes feel that things are all tethered down, and non-mobile uterus on sort of palpating over the cervix. And you can see endometrial deposits on the cervix as well. I've seen that maybe once or twice. Put it down to that. You probably need more investigations to exclude other causes, but you can get endometrial deposits on the cervix and in the vagina. There was another question about the cyclical nature of the pain. Is there any part of the cycle which is most typical? Just when they're bleeding.
Yeah, and just before sometimes as well. A couple of days leading up to, and then the first few days. Yeah.
Because it's bleeding into the wrong places that causes the pains from those endometrial deposits. Did you have any other comments to those questions, Sam?
No, really good questions. Yeah, keep them coming. And I agree. I think with the examination, yes, rarely you'll see or feel something, but I think really the main message is that usually it's normal. And so again, don't feel that a normal exam rules it out. It's still important to do it, obviously, just to check, because sometimes we might find something, and again, we might find something relating to a different diagnosis. But yes, our examination and our tests can all be normal, and it can still be very severe disease potentially.
Absolutely.
Great. So let's come on to looking at management. And again, I'm going to focus on the kind of the primary care management, but touch on a little bit as to what the specialist teams might do as well, just for our own sort of knowledge and information, really. So again, this is from the updated NICE guideline from last month. So they're recommending initially to offer a short trial of non-hormonal analgesia, so paracetamol or an NSAID, up to 3 months being a sort of typical time frame. Many people obviously may have tried that already before they come to see us if they've got painful periods, or considering initial management with hormonal treatment, and that can be the combined pill. Using that in an extended regime can be really useful. It could be a progesterone-based method, could be the Mirena. So with our initial management, thinking around simple analgesia, hormonal treatment, potentially pain management. But here again, alongside that, if fertility is a priority, referring for specialist advice early. So NICE is saying when fertility is a priority, our management should be multidisciplinary with involvement from a fertility specialist. So again, thinking about the priorities from that person in front of you as to what feels most appropriate to go for. Obviously, if they also need contraception, those hormonal methods are going to be the best ones to look at initially. So using the patient's preferences and situation to guide your choice. Again, very similar from the RCGP guideline, kind of seeing with these different arms kind of in parallel, and again, recommending that 3-month trial, and then again, a proactive review. So again, if people try something for 3 months and it hasn't worked, they may feel there weren't any other options. So again, for us to bring them back so that we can have a discussion. How has it been? Does that feel like it's helpful? If not, we can then move on. And I think around this, it's important for us to think around other factors too, especially for those people where they have then gone on to have a diagnosis of endometriosis. Again, the lived experience voice is that people really want more information. They really want more support around the impact on life, on well-being, on work, on relationships, on their mental health. So our support that we can offer to people isn't only around the diagnosis and only around the kind of very specialist support from gynae. I think there's a lot we can do in terms of supporting people to minimise the impact it's having for them, whether that's sharing information and signposting them to organisations like Endometriosis UK, who can give a lot of support, supporting them with signposting through to physio, for example, if they're getting a lot of pelvic pain. It may be that some work to breathe into their pelvic floor and relax those pelvic floor muscles and look at things like vulval care could make a really big difference for them. So we're good at this, and I think this is where we can really make a difference to people's lives. It's not just the clever surgery and treatment that needs to be done. This is really important as well. And sometimes people don't necessarily want to be referred. We're going to kind of have a look at the referral pathways and have a look at kind of when it's definitely important. I think it's important that we offer it even to younger people. And again, we'll come on to looking at the referral guidelines. It includes for under 17, so for younger teenagers too. Sometimes people don't want to be referred because they don't want to consider a laparoscopy, that feels quite invasive. And obviously that's okay. That's completely up to them. They've got to make the right decision for them. RCGP recommend documenting that if somebody does decline, linking to a number of cases where people have been kind of quite critical of the role their GPs have played at the time in not referring them when they've come back to look at things a little bit later. But of course, as ever, it's sharing options, it's sharing different pathways. And within the NICE guideline recently, they did look at options of starting initial investigation, initial management, and referring all alongside each other, not necessarily following from one to the next. But again, particularly if somebody's got very impactful symptoms, and particularly if they've been quite long lasting, thinking about trialing medication while on the waiting list, thinking about arranging those tests, but referring at the same time, recognizing that we haven't got good tests we can do in primary care that are going to help us to make that diagnosis. So sometimes referring early, certainly referring if our initial simple management that we can try in primary care hasn't been effective, certainly referring if somebody is having a really big impact from their symptoms into other areas, particularly with fertility, and particularly if there are signs of, for example, bowel involvement. We're lucky here in Bristol, both Southmead and St Michael's are accredited specialist centres for endometriosis, so we don't need to think about differentiating between referring to gynae or specialist endometriosis because our services are all specialist. And St Michael's does have a specialist service for teenagers under the age of 17. So we've got access in BNSSG to specialist centres for everybody. And don't need to make that differentiation. There's another key guideline, which is from ESHRA. This is quite a big image, doesn't project brilliantly, but I wanted to share it because it also looks at some of the other hormone treatments that gynae sometimes use with people. So things like the GnRH agonists and antagonists. So within primary care, our hormonal options tend to be around our standard hormonal contraception, things like the combined pill, our progesterone methods, our IUS. In secondary care, they may initiate GnRH agonists like the Zoladex injections or the nasal sprays that can have a really big impact on reducing symptoms, and often do so for months. They tend to be thought of as second-line treatments if the more simple hormonal treatments haven't been so effective. And often add-back HRT is used, especially after a couple of months, to reduce menopausal symptoms and protect bone density. So on the formulary locally, there are a number of options that are there as amber under shared care that gynae will sometimes initiate and then ask us to continue. And they all work in a similar fashion, can be really, really effective. So that can be useful for people as well sometimes in terms of trialing that initially, particularly if they were considering going on to surgery, to look to see what impact there could be on their quality of life with essentially these hormone blockers. And in terms of the prognosis, it's quite variable. So typically symptoms will come on around menarche and will improve after menopause. Sometimes HRT can need to be adjusted and can on occasion reactivate endometriosis, so that can be worth considering. There's not this kind of linear progression where things automatically get worse over time. The course can really vary. So sometimes people can have quite stable disease. Other people will have disease that will progress over time. And the medical and surgical treatments can give a lot of symptomatic relief. They're not essentially kind of curing endometriosis. And even after surgery, some people will have recurrence rates. And unfortunately, many people will develop a complex pain syndrome. And sometimes, even after symptoms have been treated medically, surgically, will have really long-lasting pain too, and need long-term support as part of that. There are some research projects coming. There's been lots of interest in terms of trying to detect endometriosis in different ways, using kind of much less invasive testing. Endo 1000 is a UK-wide research project that's ongoing at the moment, that's collecting data and biological samples from lots of different people, looking at the development of new testing. So there are things kind of happening in the pipeline which could be quite transformational potentially in terms of being able to support people with a diagnosis without needing to go to surgery. Certainly something that would bring down that 8 to 10 years average length to diagnosis significantly. So fingers crossed for the future. So we looked at quite a lot of different things, and I haven't gone into lots of detail with those, particularly the secondary care treatments, because I think that's not our remit, but really wanting to focus on how we can support people really in primary care. But yes, interested to hear any questions, Harriet.
So there are couple of thanks, Sam. It's a complex topic, and I think you're summarising it really well, and it's really good. The guidelines that you're highlighting are all really useful. There was a couple of questions. One was, what are the nasal sprays? Do they stop cycles? So these are the gonadotrophin releasing hormone analogues, as I understand it, and yes, they can push you into menopause, and that's how they work, and therefore stop your periods and also give you horrible perimenopausal symptoms. So often add-back HRT goes alongside that. I've had a couple of patients who've been treated with GnRH analogues and not started on HRT at the same time. There seem to be different approaches from different gynecologists. I don't really understand what the reasons not to start HRT, because people can, I mean, I've had one woman who had to stop work as a teacher because she just got pushed into this horrible menopausal state and felt better within a couple of days of starting estrogen. So yeah, but yes, there are obvious side effects to it, but they can be extremely effective at managing the pain, be life-changing for some women who've been through all the different treatment paths. Another question is that, would you agree with all of that?
Yeah, I would. And yes, with the things like the nasal sprays, it seems to be that sometimes they're given on their own for 3 months and then HRT is added in. And yes, other consultants do both at the same time. I think in PMDD, sometimes it makes more sense to go step by step so that you can see kind of the impact. But I agree with endometriosis. I would, yes, quite happily think about doing both things in parallel.
I suppose not everyone's going to get those severe side effects, but it's pretty predictable that
yes,
pushing women into an iatrogenic menopause makes them horribly symptomatic. Another question was about the preference of combined hormonal contraception. Is there any preference in terms of which ones to use, or does it not matter, was the question. I think it depends on the woman in that scenario. So in terms of managing endometriosis, it's just stopping the bleeding that's going to help with their pain and treat them, those symptoms. And using the pill continuously is certainly a really appropriate option for these women. And then I guess it just depends, if they've got any other reasons to choose a different specific progestions in their combined pill.
Yeah, I'd absolutely agree. That's right. I'd be guided by things like acne and PMS type of symptoms in terms of the progestogen choice. But those extended regimes with the pill tend to be a really effective way at suppressing symptoms. Yeah.
There is some evidence that the low dose estrogen combined pills cause less breakthrough bleeding than the 30 microgram pills. So it's worth considering that. It seems a little bit contrary to what you might expect, but the 20 microgram pills can cause less breakthrough bleeding if you're using continual regimes. And that was all the questions that we've had from that bit.
Super, thank you. So just going to go on to share some resources, and as I say, I'll send you through a summary sheet that's got lots of links on there. These are essentially the different things that I've used that I've brought together for the presentation today. But I think the patient resources are really helpful ones just to know about, to be able to signpost people to them. So Endometriosis UK has got loads of information. It's got things like symptom checkers, it's got symptom diaries, it's got lots of really good kind of education, as well as things like patient stories, which can be really powerful for people to read, especially if they've had an experience where they felt quite isolated with a lot of unexplained symptoms for many years. It can help them to realise they're not alone, which can be really powerful. There are things, lots of different kind of really good sources of information. Dr. Sese on YouTube doing some amazing talks. There's lots of different things out there. So I think kind of knowing a few of these that you can signpost people to can be really, really useful in terms of helping them understand what it is that they're going through.
I think, Sam, just in terms of patient resources, I think a lot of it's really important for these women to really understand what their ideas and concerns and expectations are, and a lot of it is actually around validation of their symptoms, and knowing that they've got something that can be treated, and that they're not just making a big fuss about nothing, which is part of the whole sort of stigma, and which you've mentioned all the way through. So validation, which patients can get from these sorts of sites and the patient stories and things.
Yeah, absolutely. I couldn't agree more. I think, yes, especially where things like the tests are normal, it can again just lead to kind of more and more questioning of, well, why have I got this pain? What's wrong with me? You know, why am I experiencing this and somebody else isn't? Yeah, so I agree, absolutely. Supporting people to understand their own experience and to recognize what's happening is really, really key. And yes, alongside that, so I've linked here to somebody telling their story, which again, I think for us as healthcare professionals can be quite powerful too. It's a 6-minute video that I'd encourage you to watch if this is something that you haven't had as much experience of. It's a lady talking about her experience, and it was shared in the House of Commons when the APPG put their sort of presentation to the House of Commons. So worth a little look in terms of really understanding the impact and why this is a really key area for us to think about. And maybe think about looking at your practice prevalence. How close is it to the expected prevalence of 10%? So remembering that quote, if you know 10 women, you should know endometriosis. I suspect many of us don't have a prevalence near that. We probably have, quite a bit lower. So again, perhaps that would be interesting to look at. Think about maybe setting up something like an Accurix link that could kind of text out signposting support for people, and maybe have a little look what was the length from presentation to diagnosis for the last couple of people who are diagnosed within your practice. How are you doing compared to that national average currently of a slightly depressing 8 to 10 years? So a few ideas for things to think about. And then I'm just going to come back to those cases where we started, thinking around what we've looked at today and whether any of that could be useful for us in terms of what to do. So our first case was diagnosed at 33, and she'd had painful periods since the age of 12, so more than 20 years. And of course, it's difficult, isn't it? At the beginning, we'd be thinking there could be lots of different factors. We'd be trying those simple regimes, trying the pill. But again, for this young woman needing to consistently be off school, needing to be consistently take time off work, A&E attendances, there's lots of red flags for us there, aren't there, in terms of the impact that these painful periods are having for her. And whilst the pill certainly was helping, because when she stopped it, things became a lot worse, it wasn't fully controlling her symptoms. And in our second case, this is less common. To present with a bowel perforation is much less common. But again, just thinking hormones, again, if we're seeing somebody with potentially unexplained symptoms relating to the bowel, to the urinary system, as well as obviously our gynae symptoms in terms of period pain and heavy menstrual bleeding, thinking to ask, is there a link to your cycle? Interestingly, again, this woman had been using the combined pill in her 20s. And again, in retrospect, could notice the link that her symptoms worsened when she stopped her pill to try to conceive, but she hadn't made that sort of link at the time. So again, thinking just about asking the relationship of those symptoms to the cycle. When hormones are used, have they made things any better? And just remembering to think about endometriosis on our differential, particularly if we're seeing people with medically unexplained symptoms. So perhaps that'll help us in terms of the recognition. So that's the end of my slides today. Thank you for joining us. And yeah, really love to hear any final thoughts or questions. Anybody got any things that they want to share?
There was one case, Sam, that we were discussing just before we started today, and a question that or something that comes up a fair amount in the menopause work that I do, and that is making sure that women with significant endometriosis are started on combined HRT. And I've had a few women presenting with sort of quite a long history of pain on pelvic pain after starting estrogen only HRT, on sort of digging around, find that there's been a significant diagnosis of endometriosis in the past. and laparoscopy has confirmed that, and we're reactivating their endometrial deposits with their estrogen-only HRT. So, yeah, combined HRT with a history of significant endometriosis, and in part to prevent any risk of endometrial cancer from unopposed estrogen in those endometrial deposits that would go undiagnosed because they're not going to be bleeding if they've had a hysterectomy. Yeah.
Yeah, thanks, Harriet. I think that's a really good practical point to make in terms of prescribing. Yeah, thank you.
There were no other questions on the chat, so to pick up on. So thank you, Sam.
Super. Well, thanks for joining, everybody. I hope that was helpful. And as I say, we'll send through the links from the slides and the resource sheet and a feedback form. So yeah, thanks ever so much.
Thanks for coming. Thanks for your questions, everyone.